Hi, I'm Marshall. I'm going to be talking about Volkmann's ischemic contracture. So this was first discovered in 1881 by Richard von Volkmann. So he noticed this in a lot of patients that were coming and complaining of inability to fully extend or pain or loss of sensitivity throughout the wrist and the forearm. So throughout that portion of time, coming into the later century, I guess, they started noticing that it was happening in people post-fractures or post-surgery, developing compartment syndrome and then progressing to this ischemic contracture. So to break it down, an ischemic contracture is sufficient blood supply to muscles and tendons. So that develops like an avascular necrosis, scar tissue forms, muscle atrophies, and then they're left with permanent contracture. Inability to move and function. So this is specifically at the wrist, at the fingers. So like I said before, compartment syndrome is one main cause of this. So that increased swelling, increased pressure, cuts off blood supply to the specific muscles. And then that scar tissue develops, and then that flexion contracture develops. That swelling also puts pressure on nerves. Specifically affected is the anterior interosseous branch of the median nerve. But also that swelling within all those compartments can affect the radial and the ulnar nerve. In more severe cases, that's all of that is compressed, and complete loss of sensation is the result of that. So through further studies and research, they've found that supracondylar fractures in children are typically the main cause of Volkmann's ischemic contracture, primarily to the damage to the brachial artery. So that's the artery that's damaged to where the muscles lose blood supply, and then throughout that series of events, the contracture occurs. So a lot of things can actually cause compartment syndrome or pressure within the compartments, and they listed such things as animal bites, people doing drugs to actually occlude the arteries and then prevent blood flow, any sort of crushing type injury, so a lot of just car accidents, or in sport related, maybe football or landing on the extremity. They categorize Volkmann's ischemic contracture into 3 different types. So there's the mild type, so that's contraction of 2 or 3 fingers. So that's digits 2 or 3, so it's typically just kind of flexion, so similar to looking like this. They don't really have a loss of sensation quite yet. They're starting to develop that. So this is primarily due to those deep intrinsic muscles affected by that anterior interosseous branch of that median nerve. So then the second type is a moderate contracture. So this is the typical one you see. This is from the picture in the top right-hand corner. So this is digits 2 through 5 in complete flexion like that. The thumb is typically adducted into the palm of the hand. The wrist is in flexion, so then that's where that deformity comes in. They have partial loss of sensation. They can feel a little bit because of the ulnar nerve and the radial nerve still being able to get their signal through. Typically what's affected is that flexor digitorum profundus and superficialis, but what I highlighted, the pollicis longus, carpi radialis, and carpi ulnaris can also be affected with this as well. So a lot of the forearm muscles coming off the epicondyle areas of the humerus. And then the third type is the severe type, so that's all the muscles involved in flexion and extension are affected. So all of those muscles have lost blood supply to them, have developed scar tissue, and are now in a permanent deformity. Typically that's a total loss of sensation, or very close to loss of sensation, and that's very disabling, and that's a type of deformity that surgery is going to be very it's not going to help a whole lot. They're going to have to do a lot of surgery, a lot of rearranging of tendons, a lot of rearranging of nerves and stuff to actually get any sort of positive movement for future treatment out of their wrist or forearm or fingers. Typical signs or symptoms you see of this, a patient will come to you and complain of passive finger flexion or active finger motion. They will have pain when squeezing at their forearm, as you'll see with pain with squeezing any sort of compartment syndrome, specifically like in the leg we've seen. they'll display like a swollen forearm, and you can actually visually see like a discoloration of their forearm. It'll be typically a pink turning red. You can also get pressure readings by sending them into the hospital, and the mark that they use is 3 millimeters or 30 millimeters of mercury. So when they receive a pressure reading of that, it's an automatic referral for a fasciotomy. So that's the typical surgery you see for a compartment syndrome, is they go on and they release that fascia so that those muscles have room to expand and disperse, and then the nerves and the arteries are not as compressed. So that's the typical surgery you'll see when compartment syndrome is occurring. So the main thing that we want to look for is athletic training individuals and individuals with supracondylar fractures. We want to note what sort of splinting and what sort of bracing is used. We want to provide better care for that, so compression of the arteries and of the nerves don't happen, so we don't have that avascular necrosis. We want to prevent any sort of further damage to the brachial artery. Any sort of signs or symptoms of the compartment syndrome, we want to immediately refer for that fasciotomy. So a typical surgery that you'll actually see for this, they've shown superficialis to profundus lengthening. So they take the superficialis tendons, they transect them in the forearm, they transect the profundus tendons, and then they actually attach the superficialis to the profundus. So they kind of rearrange your tendon structure. And so the idea of that is to gain motion back in the digits, pain-free motion, while the idea is that the profundus is kind of taken out of the picture and then the superficialis takes over. So post-surgical treatment of that is regaining neuromuscular kind of knowledge, how to regain motion, how to learn how to move with that new kind of musculature, new tendinous attachment. So that's a type of therapy to be used, is relearning how to use that new kind of musculature set up for motion, and then increase strength and range of motion with that as well. A lot of times surgery will include release of the flexor muscles, so they'll just kind of cut them, so then they have that free range, but then strength is obviously decreased in that. So it's a typical thing that you won't necessarily see, but a deformity that can occur because of something similar that you would see, like a supracondylar fracture. Any questions?